All right, so in the interest of time, I would like to welcome everyone to this AAP California Chapter 2 webinar on the maintenance of certification requirements by the American Board of Pediatrics. And what I'm going to do is I'm going to introduce the fantastic person who put us together and offer the program to us, and that is Kimberly Allen Walker. Kimberly is the MOC administrator at the American Board of Pediatrics. So Kimberly, take it away.
Thank you, Tomas. Thank you so much for having us here at your meeting. I'd like to introduce you guys to Dr. Keith Mann. He oversees the continued development and implementation of the MOC department. He provides expertise in healthcare, quality, lean methodology, patient safety, evidence-based medicine, and education. Dr. Mann joined the ABP staff in November of 2018 after serving as the Vice President, Chief Medical Quality and Safety Officer at Children's Mercy, Kansas City. He was also the Vice Chair for Quality and Safety in the Department of Pediatrics and a Professor of Pediatrics at the University of Missouri, Kansas City. He's board certified in maintaining his general pediatrics certification. I introduce you to Dr. Keith Mann.
Great. Thank you, Kimberly, for the kind introduction, and thank you, Tomas, for having us tonight. It's great to be here with you all. As Kimberly mentioned, I joined the American Board of Pediatrics about 3 years ago with the goal of making the continuing certification program increasingly relevant and valuable to pediatricians. And I think we've made some nice strides. I'd love to share some of those with you. I'm happy to answer any questions. But honestly, I still know we have a long way to go. There's still improvements we want to make to the program, and we want you to be excited about the program for continuing certification, which is a bit of a lofty goal, but one that we look forward to achieving. So I'm going to spend a little bit of time today talking about the ABP itself, but most of the time talking about some of the improvements we've made to MOC. During that time, I hope to be able to show you my portfolio and do a little bit of a demo. The improvements are great to know about, but practically knowing where to find them on our website is also helpful. So I'll try to do that as well. And then I'd love to be able to leave about 15 or 20 minutes for questions at the end. And if there is anything pressing during the presentation, again, please let me know. So to jump into a broad overview of the ABP, so the ABP has a vision and mission like many organizations, and many organizations align with what we align with. So I think as a certification body, I think the ABP, again, I saw the ABP anyway when I was not working for them, as a bit of a top-down hierarchical certification type of organization. But the reality is our vision is to do many things like you all, inspire a lifetime pursuit of learning to improve child health and advancing child health by certifying pediatricians who meet standards of excellence and are committed to continuous learning and improvement. And you can see on the lower right-hand side of your screen is a group of 4 individuals in our continuing certification department who are all available to you to help with any questions you might have. And at the end, you see Kimberly there in the middle. We'll give you mine and her direct email. Should you have any questions at any time after this, you can reach out to either one of us directly. We also have some guiding principles, and I want to mention these because I think some of them are important in the context of who we are. So the first is this concept of accountability to children and their families in this concept of professional self-regulation. And I'll get to this in a second on the next slide. But the ABP formed as a branch of the American Academy of Pediatrics back in 1934 with the recognition that there needed to be some sort of self-regulation in the world of pediatrics. So not anyone could claim to be a pediatrician, that there was something unique and special about what we do, and that required a unique and special certification, different from an internist or a family physician or somebody else at the time who could claim to care for children with equal expertise as someone who's a pediatrician. So that concept of professional self-regulation started in 1934 and continues to this day. And while I know there are frustrations with the ABP at times, I like the concept that we self-regulate. We have 300 plus volunteers at the American Board of Pediatrics. all pediatricians and pediatric subspecialists who work to write questions, think about policies, think about training, and try to really integrate the ABP with the pediatric world in a way that would be almost impossible if we were externally regulated. So again, we have lots of opportunities to improve at the ABP, but this concept of professional self-regulation as a body, I think, is important. And then I'll mention the last two because I think they're important because they're new. We really strive to align opportunities for continuing certification with pediatricians' professional practice. And I want to share some of the improvements over the last 3 to 4 years based upon that guiding principle. So I already mentioned back in 1934 is when the ABP formed. It was a branch of the American Academy of Pediatrics. They recognized that as an academy, they couldn't advocate for pediatricians and certify pediatricians with the same administrative structure. It was a conflict of interest. So they spun off the ABP. And then a bunch of things happened over the last, 60, 70 years to lead us to where we got to in 2019. And what I'll just mention briefly, in between 2017 and 2019, there was a big pushback by communities across the United States, internists, pediatricians, surgeons, about frustrations with continuing certification. Those frustrations were around the secure proctored exam. Why do I have to go to a testing center? What does cramming one exam tell you anything about my knowledge? And concerns about the limited scope of quality improvement opportunities at the time, despite it being part of a continuing certification program. That led to this idea of a vision commission, which was a bumpy road, led to the Vision Commission. And what came from that is a recommendation about the future of continuing certification from an independent stakeholder panel back to the board's community. That got vetted, rewritten standards, released for public commentary, including physicians. About 3,000 physicians commented on that. And then new standards were just released last month. Now, I'm happy to say that the new standards, the American Board of Pediatrics was on the forefront of several important initiatives. So we're meeting most of the new standards, and I'll share some of those with you and some of the opportunities that we've had for improvement and where I see us going in the future. So again, this is the last slide about general stuff, and then we'll just get right into the nuts and bolts of MOC. So here's a snapshot of the new standards. There's 19 standards, which we have to run our program by. A few that I'll highlight because they are either changes we've made recently or changes that are upcoming. So what is the idea of aligning a 5-year cycle? So in the past, there was a 7-year exam cycle, a 5-year MOC cycle. There was confusion and people didn't know when different things were due. And there was long periods of time, sometimes between even any sort of knowledge assessment. So some of the structure of the old MOC made less sense. And the emphasis was to put as much as possible in a 5-year cycle timeframe and work towards more longitudinal experience, more longitudinal learning. And I'll get to that in a second. The second major change for us is around the public display of certification. If you go to our website now and look yourself up as a certified pediatrician, you'll find your name and a little bit about your certification history. But there's nothing that signifies if someone's not certified. And so that's something that is coming in the next couple years. And it's important for 2 reasons, but we've heard a lot of pediatricians who will let their certification lapse for a year on medical leave, for example, and they don't want to disappear from our website. They think they would rather be there saying, I lost my certification in 2019 and regained it in 2020 with a short gap than disappear completely so their patients, if they look for them, can't find them. So that's coming up relatively soon. There's an emphasis on professional standing, and that will be really no skin off the back of pediatricians. It'll just be a process by which we do primary source verification of licensure. So less questions for you all about your licensure and more for us to just be able to confirm through an electronic data exchange. So a little less work for you when you go through the enrollment process than you'd have now. But the next 2 are what I'm most excited about. So the lifelong learning, there used to be 2 separate categories here. One was lifelong learning and the second was assessment. It was a complete separation of what we asked you to do as pediatricians in learning and what we did, which was assessed via an exam of some sort. And there was no connection between the 2. And so what the challenge for the ABP and other organizations is to link these 2 together. Don't assess a pediatrician's knowledge independent of helping them learn that knowledge base. and try to link the two together as much as possible in a way that helps pediatricians stay up to date, helps pediatricians learn, not just assesses their knowledge base without any support or help. And I'll share a little bit about MOCA Peds, what we've done over the last couple of years, and what we hope to do continuing into the future. And then lastly, it's around improving health and healthcare. And it's just making sure that we work to make sure that diplomates are truly engaged in quality improvement in a way that's not just making it a checkbox activity, but really helping pediatricians get credit for improvement work that's already happening in their practice. And again, I'll mention some of the things we're doing there. So let's get into the nuts and bolts a little bit. So this is your portfolio. And at the end of this, I'm going to actually pull up my portfolio and go through with you where to find some of the activities. But whenever you log into the ABP for the first time, this table, this maintenance and certification table, shows you your cycle. It says whether you're meeting requirements and what you're meeting requirements in. It shows whether you have a payment due, what your exam cycle is. So right now I'm in the middle of a MOCA Peds exam cycle from 21 to 24, and I need to pass my MOCA Peds by 2025. You can see my activity points. I've gotten 40 of my 40 part 2, 25 of my 40 part 4. I've gotten my additional, and I've had my licensure check for the cycle. So this is a quick snapshot of where you are and the most helpful quick check at our system. And then when you're looking for something, you click into the My Activities page, and you'll be able to see anything we have available to you to help close the part 2 and the part 4 points. So part 2 is lifelong learning. And there has been a lot of emphasis over the past number of years to make sure that you as pediatricians can get credit for things that are already part of your life. So the first was about 4 years ago. We started a collaboration with the Accreditation Council for Continuing Medical Education. So any CME Category 1 activity, like Grand Rounds, the national conference and exhibition that the American Academy of Pediatrics puts on, anything that's CME eligible can also be MOC2 eligible. Now, the CME provider has to register it as such, and a lot of CME providers are still don't know this. So the Academy is great. Almost all their activities are registered for both, but local CME providers don't always realize this. But if it is registered, we have hundreds of people getting credit, MOC Part 2 credit for going to Grand Rounds every month, as an example. Groups host case-based conferences that are CME eligible and will now make them MOC Part 2 eligible. And that happens in the background. So when you sign into that conference, you will automatically get CME and MOC Part 2 credit. So pediatricians are compiling MOC Part 2 credit without even knowing it sometimes, based upon just the regular stuff that they're attending. And so we want you to be able to get credit for that, because we know there's a lot of valuable things happening in the CME world that, as long as the conference is also registered for MOC Part 2 by the CME provider, you should be able to get credit. We also have some learning opportunities that are really popular with physicians that kind of come along with the fees that you pay us. We have something called Question of the Week, which is over 20,000 pediatricians have signed up, and about 5,000 to 7,000 do it monthly at least. We release a question for 50 weeks of the year. There is a short case scenario followed by an abstract and a question. The question is then followed by about a 1,250 word summary of a common topic in pediatrics, linked out to references and articles. And then you do a post-test question, a single question based upon that. That gets released every week for 50 weeks of the year. You get half an MOC point. So if you do it regularly, you complete your Part 2 activity with no problem. And after you complete 20 of those, you get 10 CME hours as well. Again, hugely popular activity. You can get it done in about 15 minutes, and I work it into my routine. I never do it every week, but once a month I do the 3 or 4 that are available for the month, and I find them valuable as a general pediatrician to help me keep up my knowledge base. Decision Skills is an activity that we release as well every year, where there are 50 case scenarios that are similar to what you see in clinical practice. They start with a chief complaint, followed by a history of and physical, followed by laboratory and or radiographic studies if they are warranted for the case, and then a long differential diagnosis that you choose from to see what you think is the most likely diagnosis from the information you have, and then a couple paragraph summary of the problem at hand and why the correct choice was the answer. There's 50 in a row, and if you complete that, you also get MOC Part 2 points, and they're mixed up of different topics. Now, I'll say one of the feedback from pediatricians was saying, I don't always want to do 50 random questions. I might want to do 10 endocrine questions. So we're starting to release 10 question, shorter decision skills topics. We have 4 out right now: endocrinology, hematology, oncology. We just released one on behavior and developmental medicine, and then one on COVID. So we have things that we hope are timely with behavior, mental health, and COVID for you all to take a look at. Again, 10 questions, you can get them done relatively quickly, and those are MOC Part 2 credit as well. And they're very popular with pediatricians. Lastly, we want to be able to give you credit for other things that you're doing. If you get basic life support or pediatric advanced life support, you can upload your certificate on our website for Part 2 credit. If you've done training in diversity, equity, or inclusion, anti-racism, structural competency, any of those topics, we recognize a lot of that is outside the world of CME and outside the world of medicine. You can simply claim the number of hours that you've had training, tell us what the course or topic was, and subsequently answer 2 questions about what you learned and what you hope to apply to your practice. And the number of hours you claimed will be translated into the number of MOC Part 2 points that you get. And then lastly, up to date is a common reference that pediatricians use. About 3 years ago, you were able to get, maybe 5 years ago, CME credit for up to date. We recently linked up to date CME with our MOC 2 program. So if you're signed up with up to date, and you can actually click that you are part of the American Board of Pediatrics if you're certified, and you can get that MOC Part 2 credit for the certs that you do for up to date. So try to incorporate things into Part 2 that make it easy for you to get credit for the work you're already doing and the learning that's already happening in your practices. I'm going to move now on to Part 3, which is assessment. And this is where we really begin to link learning and assessment together. So in the past, the only option for assessment of knowledge was the proctored exam in a Prometric testing center. We now have a new option, and you have a choice. You can do either, but the new option is called MOC Updates. It's a longitudinal assessment. And if you go to our website, you'll see this video in the MOC Updates section. It's about a 3.5-minute video that's incredibly informative and quick. I advise going there before you start MOC Updates. It's got all the information you'd possibly need. So MOC Updates is an assessment that focuses on both assessment of knowledge, but also learning. Instead of having 200 questions at once, we send questions quarterly, and you can answer 1 at a time over that quarter, or you can answer all 15 to 17 at once. Once you answer 1, you get whether it was correct or incorrect immediately, and then a 2 to 3 paragraph summary that helps explain the correct answer. Recognizing that life happens, we will drop your 4 lowest performing quarters. So if you are on maternity or paternity leave or medical leave, or just don't feel like doing questions 1 quarter, we'll drop the 4 lowest performing quarters for you. And then you can use resources with the questions. You can't ask a colleague, it's an assessment of an individual, but you can have up to date, Google, whatever you'd like pulled up, a textbook next to you, and you'll have 5 minutes per question. And if you don't know the answer, you have time to quickly research it, kind of like you might in your office setting. And you can also, we also give you Part 2 points. And so if you do MOC Updates consistently, you'll actually complete half of your Part 2 requirements. So we've tried to integrate learning and assessment even with our product here. So this is an example of what how we structured the assessment in 2021. So there were 45 learning objectives, and we give you those learning objectives in advance. There's 1 question per learning objective for 45 questions. And then we give you 15 repeat questions. So after each question, we'll ask you about your confidence in the answer and the relevance to your practice. If you have something that is relevant to your practice and that you were confident in the answer but got it wrong, you're guaranteed to see that again. You can actually bookmark it, and it will show up again sometime during the year. And the goal is to help learn. It's to say, listen, you got this wrong the first time, but if you're saying it's relevant to your practice, we want to reintroduce it to you to make sure that the learning sticks the second time around from the description at the end. And then there's new knowledge. We released in 3 articles, up to 4 articles with 2 questions per article. And then there's some time-sensitive questions. So a couple of years ago, we released 2 questions on measles when there was an outbreak in several communities in America. Last year, we released 2 questions on COVID. Those questions actually don't count towards your final score. They're just there to help learn on a timely topic. So in summary, you get between 60 and 72 questions per year, or 15 to 18 questions quarterly. So I'll go through these next slides fairly quickly. This is just a snapshot of what MOCA Peds looks like. So you'll see in exam content, I mentioned there's feature reading. Even if you don't have access to that journal, we've cleared all of them. So the articles are there for you for free. You can download them. The learning objectives are there in advance, and then those will feed into different questions. So the questions, as you can see, are pretty straightforward. A full-term infant appears well at birth, and it goes through a short history. Which of the following congenital affections is most likely? You can see the timer on your upper right that kind of ticks down over the course of 5 minutes. You then obviously click the bottom button to submit your answer. And as I mentioned, you'll quickly get a question about confidence and relevance. And as again, I mentioned earlier, we use that to determine future questions that you will receive, both to make your exam more relevant over time, and then also to re-release questions to you that you got incorrect. Once you select the answer, you'll get immediate feedback, whether it was correct or incorrect. You can bookmark a question, and you'll be able to find that in your question history, which you can see there on the left-hand side. So I would recommend, if you're in MOCA Peds, bookmark anything you get wrong, because you're likely to see those again. And if you've marked it relevant and got it incorrect, you're almost guaranteed to see those questions again. And then it's followed up with a rationale. Again, 2 to 3 paragraphs with a reference that should help you learn about the topic. And again, you only have to do 1 question at a time. So if it's something you got wrong and you'd like to learn more, you could actually pause right then if you have an opportunity and pull up that reference. And lastly, as I mentioned, the question history up there on your left is available for previous questions. We've gotten great feedback on MOCA Peds so far. So feedback about the questions themselves, 77% agreed that the question difficulty was appropriate. 78% agreed that the questions assessed the clinical judgment going beyond just factual recall. And 79% felt they had time to answer each question. 90% of participants felt like they learned, refreshed, or enhanced their medical knowledge based upon participating in MOCA Peds. And 60% already applied that knowledge to practice improvement. And 21% said, not yet, but I plan to going forward. So we really believe, and we have hundreds of examples given to us as write-ins of where practice improvement has happened. And it's anywhere from, I didn't realize the otitis media guidelines had changed and I've updated my practice for something very common, to I hadn't seen Kawasaki disease since residency. And then 1 week after I did MOCA Peds, a child with Kawasaki disease came into my office, and it helped me recognize it more quickly than I might have otherwise. So anything from things we see more common to less common. Here's the rollout for MOCA Peds. You can see 2019, 20, and 21, general pediatrics, and then most of the specialties rolled out. And in 2022, adolescent medicine, pediatric cardiology, pediatric emergency medicine, and pediatric hematology and oncology will roll out. So now moving on to part 4. So part 4 is the related to quality improvement, and it's the area that's I think most difficult for pediatricians, partly because QI is hard and because we weren't all trained in it in residency. It became a requirement of training really over the past 10 years. So our goal is to encourage people to engage in quality improvement activities in their practice, because we know that QI results in better processes and better outcomes for children. So good QI works. And we want to be able to give you credit for the work that you're doing in your practice, even if it doesn't result in improvement. The effort there, the movement towards making an improvement part of who we are is what's important to us. And there's multiple different ways to get credit. So one is through multi-institution or large-scale QI projects. So as an example, there are multiple subspecialties which run national learning networks or collaboratives around inflammatory bowel disease, juvenile idiopathic arthritis, cystic fibrosis, things like that. And there are other that are hospital-based, like central line-associated bloodstream infection improvements and other major safety initiatives. So those are big multi-institution, large-scale projects that people get credit for. More commonly, a lot of people get credit for workplace-based projects. And those workplace-based projects can either be submitted directly to the American Board of Pediatrics. We get about 2,000 submissions per year, or to a portfolio sponsor organization, which is an organization that approves projects on behalf of the American Board of Pediatrics. And so there are 86 organizations which approve their own workplace-based products for the ABP. About 50 are children's hospitals. There's a bunch of clinically integrated networks, but there are also 5 American Academy of Pediatrics state chapters that run small QI collaboratives for the pediatricians in their state and approve those projects on behalf of the ABP. So there's a wide range of, and then the American Academy of Pediatrics National is also a portfolio sponsor, and they approve as well. So we get about 10,000 pediatricians approved through that mechanism, and it's for doing QI work that's happening in the context of practice, which is what we like. And those who are the portfolio sponsor organizations, it allows them to engage pediatricians and use MOC Part 2 as kind of a small carrot for engaging meaningfully in QI work. Also, if you are part of an NCQA patient-centered medical home, we have a very streamlined application online where you upload evidence that you're part of that medical home, either a certificate or a screenshot of their website, answer a few questions about the work that you're doing through NCQA, and you get all your Part 4 credit for a cycle, because NCQA's QI standards are very similar to ours. So there's no reason to make you do extra work because we know you're already doing it through NCQA. We have about 150 pediatricians get credit per year through this that are leading QI at a local, regional, or national level. And that's a very popular activity for those doing the work, but not common, about 150 per year. And lastly, we do still have online performance improvement modules, but as we've increased the opportunity to get credit in your workplace, there's been a drop from about 20,000 applications per year through these online performance improvement modules or completions down to about 6,500. So it's been a 63 to 65% drop as people are doing their own QI work and actually not relying on our QI modules that we produce as much. And we see that as a sign that we're moving in the right direction and a sign of success. Here is the QI project requirements. And so for people who love QI experts, they hate our requirements because they're relatively straightforward. For people who don't know QI, they're probably a little too hard. So what we try to do is put reasonable requirements out there that really don't meet all regular QI standards, but help get the ball rolling. And so the goal is to find something that you'd like to improve, so a known gap in quality, have some quantified goals within a specific time frame. So we'd like to improve the rates of PHQ-9 depression screening in our practice from 30% to 70% within a year. Then measures to track progress, at least 3 points of data. So again, if you're thinking about the depression project, what was my baseline data? What intervention did we put in place? And what did my data look like at 6 months? And then was I able to sustain that improvement? What does my data look like at a year? So it's relatively straightforward, but 3 points of data. And then an attestation that the physicians that got credit meaningfully participated. And if you're in a practice of, say, 10 pediatricians, only one person has to fill out the QI application. All 9 others can get credit by simply attesting to participation. So the leader gets a group code, and then when the other physicians go in to log their participation in that project, they use that group code to pull up a simple attestation form, which is a couple checks that say I participated meaningfully in that work. Here's an example of a project that was submitted about 3 or 4 months ago around improving the yield for adolescent depression screening. So this group had done a previous project to improve the rates of depression screening. And once they got their rates up, they actually realized that their prevalence on their screening tools were only about 4.5%, which was, sorry, their positive results were only about 4.5%, which was substantially lower than their 15% or so expected prevalence that they thought in the population of patients. They thought there'd be about 15% of patients that had depression or positive screens. So they aimed to increase the percentage of positives. That was basically, they wanted to find more kids who were truly depressed based upon their screening. They did a number of interventions that you can see at the bottom, picked a measure, a goal, where they got the data source from. And this is basically the whole application. And then this was their data on the right-hand side. So they did baseline measurements and they followed their data each month for about 8 months. And they were able to almost double the rates of positive screens, which they reflect really proudly on, that they're now able to get resources to those adolescents that needed it when before they might not have identified those adolescents in the first place. So this group was really proud of this project and had some really nice reflections. But what you see online is essentially their entire application. During COVID, we also released a COVID improvement project. It's a similar application with similar standards, except it's a little bit more streamlined for COVID, and you only need 2 data points. So just a baseline and post-intervention data, knowing everybody's scrambling to get new things up and running with COVID. We do have a checkbox for what the topic is about. So whether it is immunization or PPE or new triage techniques or rapid testing, whatever it is that the office has tried to improve, we'll report back to the community about what all that improvement looked like next year. But for now, it's a streamlined way to get credit for Part 4, and over 500 pediatricians submitted COVID improvement projects just in October alone. And these are 2 recent projects that got submitted. One was around telehealth utilization. And you can see this group aimed to increase the telehealth visits to at least 75 per week for acutely ill patients over the course of about 2 months. And the second was around COVID vaccination rate. This group aimed for 100% COVID vaccination uptake in the eligible population. Now I'll share their submission, they reached about 60%. But again, the credit wasn't based upon their end goal. The group was proud of their accomplishments, even though they didn't achieve 100%. And obviously, we still gave them credit for that. So it's not like we want to judge the level of improvement or how close you got to your goal. The idea is to get all pediatricians thinking about the importance of improvement. And if we all look at ourselves and our practices, there's always opportunities there. What if you need help with a project? So we do help with concept review. We review applications after submission and get back with you for help if you need it. And there's even some coaching available. So we have a couple QI experts in our group, but the person who reviews most of the applications is Patience Lino, and I put her email up on this slide. And if you don't know quality improvement at all, we want to give you the time to learn quality improvement. So we put together a module called Virtual Quality Improvement with simulated data. And it's an online module that starts with reading about quality improvement, learning about quality improvement. There's a 25-item assessment or quiz, followed by the opportunity to do 2 mock QI projects on 4 different topics. There's a topic for an ambulatory physician, somebody who helps run a practice, somebody who is in an inpatient setting, and then a researcher. The idea is that if you can learn QI in one cycle, we hope that you'll apply it to the next. So you can get all your QI credit for one cycle by doing this virtual QI in hopes that you apply it to the next cycle. So I'm going to pause there for a second, and I'm going to try to see if I can switch my screen here and open up my portfolio. So can I just get a comment from somebody that they're actually seeing my portfolio now and not my presentation?
Yes, it looks good.
Perfect. Okay, so as I mentioned, this is my portfolio, and I just wanted to show you where a handful of those things are that I've shared about today. So if you go to My Activities, it'll pull up a screen that shows your self-assessment, which is part 2, quality improvement part 4, and then a series of other tabs. You can see there's a CME certificate tab. Anything you do with us will log your CME credit, and you can always find it here. You can always find the old activities you've completed here, and you can bookmark activities, and you can find it up here. So I'll start with part 2. I mentioned a couple activities. One was question of the week. So if you just type in QOW, kind of scroll down, there's a couple things there, but you can see question of the week is available to you right here. You view it and launch it, and I've actually just got it pulled up for ease here. And so again, I just want to confirm, Tomas, that my screen switched to showing now question of the week and not my portfolio.
It is showing the 17th, November 17th
Perfect.
item. Yes.
Awesome, thank you. So this is the homepage for question of the week. This is the question that's available this week. And you can see those that are available in November, and you can kind of scroll back to previous months and see whichever ones you'd like to do. So you can see ones that I've done already. So the ones that are kind of highlighted are ones that I've done already. And you can see I haven't done any yet for this month. So I'm going to go to one of the ones I've completed already and show you just the general format. But these are all developed for general pediatricians on common topics. So this is about infant botulism, so less common but relevant to practice. And it's a quick case scenario. Goes to a pre-test that's graded, but just so you know where you stand in regards to your peers. There's an abstract on the topic. The abstract is pulled from something recent that's in the medical literature. There's a level of evidence down there, so it's clear what level of evidence the research is based upon. 1,250-ish word or so commentary with links to learn more about certain topics if you liked. The authors love history, so some of the links are to the historical part of the problem, but then obviously more recently, there's links to the more recent information that's available for pediatricians. So this is a summary, and they all look very similar. You can see over here on the right, you can download the PDF if you like the information and want to save it. But we also conclude with some key takeaways. And so there's like the key learning points for every topic are included at the end as well. So again, discussion, and then you actually answer your final question. So there's a pre-test. At the end, there's a post-test, which I can't really show in this current screenshot. And then you go on to the next question if you'd like. So again, 20,000 pediatricians do this regularly. Sorry, I have done this, and about 5,000 to 7,000 do it on a regular basis. The other thing I'll share really quickly, if you want to pull up, is this decision skills. And again, I'll pull it up just really briefly because I think we're doing, let's see here. Yeah, we're doing okay on time. All right, so a little slow. So I'm actually, here we go. So here we go. So here's the decision skills case. So a question, a 4-hour-old infant has a blood glucose concentration of less than 40. In addition to intravenous glucose, which of the following is the most appropriate next step? You have a patient history, physical exam, and diagnostic studies, and then the question, and then a problem summary. And again, we have these now there's 50 questions. And so, 20-day-old infant born with bloody stools, a 2-day-old newborn with bright red blood in the stool, 16-year-old girl with primary amenorrhea, all the same concept, patient history, physical, diagnostic studies with a question at the end. The other thing I'll just remind you of just really briefly, I won't pull them up, but if you wanted to learn, you wanted to claim your credit for diversity, equity, and inclusion, again, type in diversity. This will link you to that site. And if you wanted to claim it for pediatric advanced life support, use the search, pull this up, and you'll be able to find it from that site. Similarly, if you click on part 4, you can get your quality improvement projects. So you click on here, it'll link you to the COVID application. Your QI project is our small group application for anything non-COVID related. If you wanted to claim credit for NCQA patient-centered medical home, it's over here to the right. And here's where we have the online modules. So there's multiple online modules listed. If you wanted to do so, all of the EQUIT modules by the AAP are also here. And then again, because I shared about it earlier, if you type in virtual, it'll pull up virtual QI for you. And this is the topic that you can learn about QI and get credit for your cycle if you wish. So that's just a quick look at my portfolio. I'm going to go back to my presentation now. So I mentioned earlier that we have a focus on improvement. It's one of our guiding principles. So starting last year, we got our first baseline measurement of how we're doing. So we asked 15,000 pediatricians who enrolled in their cycle, based on your last 5-year cycle, please rate your agreement with one of the following statements based on your experience with, and then it was either part 2 or part 4, that products that we offered. And this is actually information now from this year. So we got 10,000 pediatricians answered last year. The data is pretty similar this year, although we're already seeing some improvements. So whether part 4 facilitated improvements in patient care, 72% either agreed or strongly agreed this year. That's up from 66% last year. The part 4 I did was relevant to my practice. 77% is up from 75% last year. And then my part 2 activities facilitated staying up to date or were relevant to my practice. And these in the mid 80s are up from the low 80s last year. So I think some of the changes we're doing are making a difference, and we're committed to continually both asking pediatricians what they would like to see improvements in the program, as well as measuring those to make sure we're making a difference. So I'll wrap up with one slide with what's next and then open it up for discussion. We should have at least 15 minutes there. So we're working on health equity integration, making sure that health equity becomes a part of the MOC program. We started out by including questions about whether or not you stratified your data for QI projects on race or ethnicity. We're finding that very few are stratifying their data. And starting next year, we'll put QI modules in place to help you either collect data for the first time if you're never collected race, ethnicity, or language data. If you are collecting it but don't believe it yet or aren't sure about how it's being collected, help with data validation. And if you're collecting it and you feel good about the data but don't know how to use it or interpret it, help with the interpretation. So a lot of work next year that we should be able to launch in the end of 22 or early 23 to help all of you out to identify different issues where the healthcare for different races, languages, populations is not equal. We also are simplifying our MOC points. So in the past, as I mentioned earlier, you needed between 40 and 60 points for part 2 and 40 and 60 points for part 4. We're just simplifying it. So starting in January, it's 50 for each. In order to make sure you don't have any additional QI requirements, we're making all of our QI projects standardized to increments of 25 or 50, both forward and backward. So if you did a QI project that you got 20 points for 4 years ago, then in mid-January, that'll now be worth 25. You'll get the extra points awarded to you automatically. So we're not increasing the QI requirement at all. We're just standardizing the point value, and that's allowed us to simplify our points system. I can't tell you how many calls we get about the confusing point system we have. And then lastly, we hear from different people that sometimes pediatricians will say, turn down a QI project because they've already completed their points for that cycle. And we want you to be able to do QI when it's available. So if you have an opportunity to do a third QI project in a 5-year cycle, we'll allow you to carry that project over to the next cycle. So for pediatricians who exceed their QI requirement in one cycle, they'll be able to carry forward up to one project forward to the next. And so we'll roll out a lot of that next year. So that's it. Kimberly Allen Walker, who you met in the beginning, her name and name and email are on this slide. She's a direct contact for you. She can help any individual through their portfolio. I'm also available as well to help out with whatever you might need, answer any questions you might have about MOC, or hear your feedback about the program and how we can be better going forward. So I'll pause there. We got about 15, 16 minutes left for questions. Tomas, thank you so much for the invite. I will stop sharing my screen and do my best to answer any questions that come up.
Yes, thank you, Keith. We have 2 questions actually in the chat box. Actually, a third one just came up. But Dr. Rajashekar was asking on the relevance of QI projects for a small practice who is not in academics. I don't know if Dr. Rajashekar, you want to unmute yourself and explain a little more, but he's concerned about the fact of finding the usefulness of engaging in such a project and the possibility of not gaining the necessary knowledge and only doing it just for the points,
Yeah.
the requirement of the points.
Yeah. So when I shared the data about part 4, that about 76% of people are doing work that results in improvement. The good part about that is it was higher than I thought from where we were at our baseline data. The bad part is obviously the inverse, which is 25% of people are doing QI that they're not finding valuable. So I think there's a couple options. One is to try virtual QI. Try to learn about quality improvement in a way that you can apply it towards your next cycle. Option 2 is to tackle something small and meaningful. So a common project that pediatricians and small practices tackle is to improve influenza immunization rates. It's a time-limited project. Usually people are giving influenza immunization over the course of several months during the year. They might know the general rate from the year prior, maybe some baseline data that someone could find or a practice administrator could pull, and then work to improve the vaccination rates from one year to the next. So that's a common project that small practices do. Other common projects include depression screening, not even increasing the rate of positive, but increasing the percentage of people who get depression screening. If you don't have a practice administrator or somebody who can pull data for you, we have small practices doing small numbers of chart reviews, like 10 chart reviews a week to be able to document the data. And sometimes 10 is a small enough number that's manageable, but you can still get percentage-based improvement if you're moving from a 30, 40, 50% to 60, 70, 80%. So those are some things that I've heard other small practices have done, and you're more than welcome to reach out to me afterwards if you have an idea about something you'd like to improve in your practice. We can probably help you think about how to make it a little bit more seamless.
So Dr. Banzuela was asking, how do we know that a CME event or project is also has MOC Part 2? And this is for CMEs that are not events that are not AAP events.
Yep.
Like PriMed and Symposia Medicus. How do they know? Because when we have events in our chapter and we offer MOC Part 2, like the symposium, we actually advertise. You get so many CMEs, and you get the equal amount of MOC points.
Yep.
But how do you know for other types of events?
Yeah, if it's not advertised, it's probably not eligible for MOC Part 2. If the only other way to know is to log into your portfolio about 2 weeks after you completed the event and see if there's something there. That would be one way to confirm on the back end. But most organizations advertise both CME and MOC Part 2. So usually it's pretty obvious on the upfront, just like you all do.
Does anybody have any questions? You want to come on screen or just unmute your microphone to?
Yes, Thomas, this is Dr. Rajshekhar.
Yes.
I have a question. Dr. Mann, thanks for this nice presentation. My only comment is CME is very useful to keep up to date with the knowledge. And MOC, I feel it is a burden on solo practices. How much it is helping to improve by just doing one project, I don't know how to measure it. But if at all anything, because the board is making so many changes over the period of time, if there's one thing I would like to see go, is Part 4. The other 3 are relevant. Part 4, I still feel is a waste of time, I will say, for solo practitioners. We are not doing any research to contribute so much to the academic world. There are academicians who will do all these things, and we just go attend lectures, read about things, and pick up from there and implement those things in our practice. But we ourselves doing some research and then implement those things, I don't know what to say. It's just my comment.
No, I truly appreciate the concern. I think the kind of argument back is that we know, based upon really good literature, that there are health outcomes in children that can improve. Immunization rates, rates of screening for different mental health disorders, rates of screening for social determinants of health. There are major gaps across zip codes due to healthcare disparities. So we know that there are gaps in child health. And the goal of quality improvement is for anybody, an individual practicing physician in a solo practice or a group practice or an academician, to be able to look at one thing in their practice that they would like to do better and work on that over the course of a year to two. I don't mean to say it's easy in any way, shape, or form. I didn't learn QI in training, but had the luck of being identified as someone who might like QI in my 30s and built a career off of it. So I think, go ahead.
I have a comment on that. This is something unconsciously we are doing all the day. Say, for example, I'll give you. I practice in Southern California.
Okay.
And majority of our patients are managed care medical patients. That means we have various measures that the insurance companies measure from what we do. Say, for example, my immunization rate in my office last year was, say, 90%. The following year, if it is 95%, I know that from the data that they have, because they give us a monthly improvement as well as yearly improvement on how we are performing, and our payments are based on that. If we perform well, we get better paid, and if we perform low, we get less payment. So that data is already available, how we are performing and what we are, without saying this is what I'm doing to improve the things, we are already doing it and we are improving our quality of care provided in the offices. Can the board take that kind of information and apply that to part 4?
Yep. So great question. And it's kind of a two-part answer. So in the short term, that work is absolutely eligible for part 4. Unfortunately, it's still a submission process. Now, if you have the data available, the submission process should be relatively seamless. We would like to do more data exchange in the future, so that type of information is available directly to us. The hard part is there's countless examples like you just gave, where an insurance company or has information available. We don't have the bandwidth, resources, capability to link to everybody. Like the ACCME is easy to link to. It's one organization provides CME. So we link to them and we get all of the data from all pediatricians. We would love to do more data exchange, so you get credit for that behind the scenes without even having to worry about it. So it's something we're striving for, but I think that'll take some time. In the meantime, that work should count already. And if you have any questions, please feel free to reach out to me personally, and I can even help you think through what that application looks like to make sure you get credit.
Thank you very much. I will provide that information to you how we are doing this, because our HMO plan in Southern California called IEHP, Inland Empire Health Plan, has 1.3 million patients. Majority of them, nearly 90%, or 85% of them are children. And they have the data every year, data on every physician on how they are performing. And I will share that information with you through Tomas in the next few days or few weeks. So maybe we can have some conversation on that, on how to credit those things for part 4. So that will save a lot of time for us as solo practitioners. Thank you again.
Anybody else? Well, all right. I guess we can call it a night. Well, thank you so much. We really appreciate it, Keith. Thank you for your thorough presentation. And we're also fortunate that we got this recorded, so we will be able to share it with our members, because it was you took it from point A to point Z with the ABP And it was very educational even for me because I am the one who organizes a lot of the QI projects for part 4 with the chapter, the quality improvement projects. And I have been able to submit applications for part 4 projects and successfully. And we're very thankful that the ABP makes it so seamless for us. I mean, there is a process, but it is not impossible. It is not difficult. We just got to know the process.
Well, Tomas, thank you so much for
Yeah.
having me. I just chucked my email in the chat, so anybody that wants to email me directly should have access to that. And again, if the
Great.
presentation's recorded, it's on the last slide.
Very well.
But great seeing you, and thanks so much for the invite.
Thank you. And we will be sharing the PowerPoint with everyone.
Sounds great.
Thanks, everybody. Have a good night.
Bye-bye.